And then I guess without further ado, let me introduce Dr. Bloom. We're pleased to have him join us today. He's a specialist in physical medicine and rehab, and he's been serving patients for over 3 decades. He graduated from U of M and then got his doctorate from Michigan State. He completed his specialty training at Northwestern in Chicago, and he's been practicing in Michigan ever since. Currently, he's the medical director of rehabilitation for St. Joseph Mercy Hospital Rehab Department in Ann Arbor. And he's also the medical director of the COVID recovery programs, which is why he's here today. He's certified in brain injury medicine, and he's lectured extensively about brain injury, concussion, chronic pain, and many other neurologic conditions. So without further ado, let's welcome Dr. Stephen Bloom to our Lunch and Learn today. Thank you.
All right. Thank you, Dave. I appreciate Beth for introductions too. Well, glad to be here. I would be remiss in a corporate entity like Trinity not to point out that for David, we're no longer called St. Joe. Breaks our heart. It's now Trinity Health Ann Arbor, and so if I don't say that publicly, then I get in trouble. So nice to meet everybody. So we're so glad to be here. We're just down the road. It was like a 10-minute drive for us to get over here. So I'm very pleased to be here, and we love these kind of community outreaches. So I'm here to present on a subject that we all are new to. So it's kind of fun. In my 30 years, I've never been able to develop a program from scratch that's never been done before. Typically, we're reinventing programs and things like that. But since COVID's new to us, it's new to the medical community too. So this was kind of an issue in evolution that as we all learned together in long COVID, we were able to do that. Yes?
Could you speak up just a little bit, please?
I will, yes. And so I got involved as my specialty is something called physical medicine and rehabilitation. I'm a physiatrist. How many of you out there know what a physiatrist is? I'm very impressed because I'm still trying to explain that to my mom what I do for a living. A physiatrist is a physician who specializes in issues related to disability or function, okay? A good description of what we are is we're a neurologist, an orthopod, a rheumatologist, and an internal medicine doctor, all rolled into one, all right? And so we take care of patients with disabilities. Traditionally, we'll take care of patients with spinal cord injury, brain injury, stroke, multiple trauma, amputations. And the way we fell into the COVID area is with these long hauler symptoms that people are having after COVID. These are areas that affect a lot of function in the human body, so that's how we got involved. All right, so today we're going to be talking about COVID and particularly long COVID. You've heard this term being used. This is kind of what's being used, I think, across the country and across the world as the main descriptor of this. But there's a lot of different names of it. Basically, the post-COVID condition, it's an umbrella term. It's to describe all these different symptoms that patients have after they've had at least an infection that's confirmed by SARS-CoV. And when it's chronic, meaning those symptoms are persisting longer than 4 weeks after the infection, okay? So many people get COVID, they resolve from it, and they don't have any issues. But for those who continue to have issues, after 4 weeks, we're calling it long COVID. Officially, in the medical world, we call it the PASC, the post-acute sequelae of SARS-CoV. The National Institute of Health describes this as long COVID. There's these other terms you guys will hear: post-COVID syndrome, long COVID, long-term COVID. Oftentimes, people on the internet describe these post-COVID symptoms as long haulers. I've never liked that term. For some reason, it makes me think of truckers, and obviously people other than truckers get long COVID symptoms too. So long COVID, post-COVID, they're all a variety of things. So there's a lot of different patterns for patients who continue to have symptoms after COVID, and we're still trying to figure out why that is. There's those with persistent symptoms, so they had COVID and a bunch of their symptoms never got better. Now, there's a whole nother subset that patients are getting delayed onset or late sequelae of these COVID symptoms. In other words, new ones either evolve or certain symptoms get better and others are just left over, and so you're more aware of them. And so we kind of lump those together. There's a whole bunch of different pathophysiologies that cause that, or processes that cause that. And there's a lot of complications on how they present. So the long hauler patients are very complicated. I think of them almost like an onion with a lot of layers. And we're constantly peeling off those layers, trying to figure out what's causing each aspect of it. Now, I'm not going to go through each of these reported symptoms, but it's extensive. Look at all these things: issues with shortness of breath, fatigue, brain fog, cognitive issues, pain in the muscles and the joints, so-called myalgias, arthralgias, difficulty with balance, difficulty with shortness of breath, cardiac issues. It turns out that the post-COVID pathophysiology, or what has actually happened in the body, attacks certain tissues in certain individuals. So the most common things we see are this, and this is what we see in our clinic every day: issues with fatigue, shortness of breath, joint pain, cognitive issues, that's that brain dysfunction, that difficulty with thinking, muscle weakness, peripheral neuropathies, tingling, numbness in the fingers and the legs. Problems, there's actually very severe issues that happen, including stroke and things like that. Mood disorders, very common issues with depression after this. Chronic headaches, something called POTS syndrome, which is tachycardia and low blood pressure. So people are passing out a lot with this. And difficulties, COVID-somnia just means difficulties with sleep after COVID. Now, not everybody has all these. A lot of people have multiple issues that overlap with all these things. So it's kind of a big hodgepodge. When we're doing a workup for post-COVID, we get a referral to our clinic, the initial infection is over, you tested negative, but boy, you're still having all these symptoms. There's a variety of different tests that your doctor may do, or you do once it's referred to us for treatment, on ruling out other causes of this. It might be a cardiac issue, so cardiac testing like echocardiograms, EKGs may be needed. It may be a pulmonary issue, so x-rays or CAT scans or pulmonary function tests may be needed. It may be an endocrinologic problem, so we'll be doing testing on thyroid, blood testing for rheumatologic factors and things like that. So the workup of a long hauler post-COVID patient is pretty extensive, and it involves a lot of different testing to just look where we at, what might be causing their symptoms, and more importantly, how we're going to treat that. So that's why the workup often takes a little while to figure out what's causing all this. Now, the incidence of long COVID. How much are people getting it? How many people are out there getting it? It's pretty high. Just our friends right down the road at U of M did the very first study on this. And they looked at patients who had survived COVID, but were still presenting for at least 4 weeks later with these symptoms. About 43% of the respondents that they saw, so almost 50% of patients had persistent symptoms at the 4-week mark. All right, that's significant. Those patients who were hospitalized initially had a higher rate, and it was higher in both women and people who had what's called comorbidities. We'll talk about that. So that's a trend we continue to see this day, even though we've got better treatment for the acute phases of COVID, better treatment for the long haul COVID. These numbers are staying pretty significant. There's a snapshot from the state of Michigan epidemiology site that talks about the incidence of long hauler symptoms just in the county of Washtenaw. And so here, about 9,000 cases estimated, and this slide's a little dated, but it's really about 1/3 to 40% of all the patients are having those symptoms. So here in Michigan, we're no different from around the country. Anywhere from 30% to 40% of all patients who've had a COVID infection continue to have problems ongoing. So pathophysiology, what causes long COVID? We know that it affects various systems in the body, whether it's brain, neurologic, lungs, heart, musculoskeletal, metabolic processes, or a combination of both, leading to chronic fatigue. It's a variety of different systems that are being affected in this syndrome. Several studies have examined these long-term effects, and they're similar to previous viruses. People have probably heard about SARS in the old days, or something called MERS. This is very similar, but it's also different, and we don't know why. It's probably because this type of viral infection was not as common as, or as virulent as what the COVID is. In other words, SARS, which is a severe acute respiratory syndrome that went through, it's a COVID-like infection, but this one seems to be different. So it affects the body a little bit different. And again, they found that these chronic fatigue syndromes from previous coronavirus infections had similar amounts, but for some reason the symptoms in post-COVID are lasting longer. And in different studies, the lung function abnormalities and the cardiac abnormalities are seen for about 6 months after patients with severe infection. So it's prevalent. So we're trying to figure out why the long haulers get this. your body clears the virus. The virus goes away. It's not in your body. It's not the virus that's causing the problem. What likely is happening, as best as we can tell at this point, is that the virus triggers your own immune response, something called an autoimmune response, where your body's own antibodies are attacking the tissues. We don't know why that occurs. It's a trigger, but it's the best explanation of why this occurs. Now, in certain patients, your body will attack certain tissues. So Dave might get an attack on his lung tissues. I might get an attack on my heart tissues. Why? We don't know. It might be a genetic thing. It might be comorbidities. It might be just random. We don't know why that is. But we do see this presentation that the autoimmune response is your own body reacting to the infection. Seems to be different in different patients. It's an inflammatory response. And so as we look in ways of treating that takes a different approach on that. There's kind of two bodies of thought as we're looking into how we research this. One is exploring what goes wrong in the body in the first place, can we prevent that? And the other is, let's look for reasons that people are getting certain involvement with post-COVID and address that. We tend to look at both of them. We're not splitters, we're kind of lumpers. We put it all in together to try to figure out how we're going to diagnose and treat each of those symptoms. We do know that there's major risk factors for developing COVID. And we're trying to educate people to do everything they can. Some they can prevent and help minimize, some they can't. We do now know that if patients have diabetes, that are higher risk for developing COVID, or long COVID, I should say, and COVID also, by the way. So the issue here is trying to control blood sugars in those who are diabetic and minimize that risk of getting it. Another predisposition is there clearly is a genetic component, and we haven't identified why that is, but certain patients, their own genome, their own DNA, makes them have a higher propensity for developing long hauler symptoms. You can't do anything about that. We do see that there's a higher incidence of previous Epstein-Barr virus. That's the EBV virus that people often have with chronic fatigue, which has been studied for many, many years. For some reason, there's a slightly elevated titer of EBV antibodies in patients who have long hauler. So the feeling is that you're probably already a little immune compromised because of that previous infection. So if someone had a history of EBV, then we want to be careful and make sure you prevent a COVID infection as best you can. And the presence of autoantibodies falls along with that. In other words, some people from previous coronavirus infections already had the antibodies sitting there. So the COVID infection triggers another response to make it worse. So those are all factors we look at when we're studying this. And then the long COVID really, it's kind of a bigger picture on things too. Everybody's always looking for that one little magic reason, that little reason I got this. It's probably multiple things. And once we're treating patients, trying to get them past that, what did I do wrong or what did someone else do wrong, we kind of try to get past that there's, though you try to maintain as much health as you can, try to prevent getting COVID, and once you get it, do the right things. You can't beat yourself up on one cause that made you get it versus someone else. And we get that a lot in our patients, is why did this happen to me? I did everything right, or someone else got the same infection at the same time and it didn't affect them. It's because of your own response. So it's really challenging on how to identify who's going to get this and how to prevent it. But we clearly know that if there's a pre-existing health condition, diabetes, asthma, hypertension, you are at a higher risk for getting long hauler. Patients older than 50 tend to develop this more often than those who are under 50. Patients who are overweight also carry a higher risk of getting long hauler symptoms. We don't know why that is. Women get a higher incidence of long hauler symptoms. Again, we don't know why that is. And with patients with 5 or more symptoms during that first week, in other words, if you just have a fever, you're pretty low risk for getting long hauler. But if you had a fever, a cough, arthralgias, which are joint pains, or myalgias, which are muscle pain and shakes and tremors at night, that's a much higher risk for getting long hauler. In other words, the sicker you were during that initial infection, the more likely you'll get long hauler. So how do you diagnose it? There is no test. There is no one blood test or x-ray or anything I can do or that I do to say this is definitely long hauler. It's historic having the infection itself, and it's interesting. There's a lot of people who are convinced they have long hauler who never were sick and never tested positive. But there's also a lot of people who present to the clinic who were sure they got COVID 4 or 5 years ago before it was out, and now they got long COVID. So we try to sort through those. That's very rare. But a positive viral test is definitely needed when we have someone come in the clinic. We want to confirm that they actually had COVID and that this wasn't some other condition. Lab testing really is looking at the abnormality. So for instance, if a patient has long COVID and feels very fatigued, we're definitely going to be looking at thyroid function. Or we'll be definitely looking at their blood counts to make sure they're not anemic or something that we can treat with that. And a basic panel blood test would be done usually at about 4 weeks. If you had COVID 3 weeks ago, 2 weeks ago, there's no and you're still feeling symptoms, there's no reason to rush out and kind of get a whole bunch of blood tests. But if you're still having symptoms after 4 weeks or up to 12 weeks or so, you should be definitely seeing your primary care physician or a COVID specialist on looking at why you're still having these symptoms. And then consider additional testing even further down the line. But starting out with your primary care physician is a perfect place to get started with that. I'm not going to go through this. This is a basic laboratory test. I use this lecture for our residents and med students also. So how do you treat this? All right, there's no magic pill. There's no magic shot. I know everybody's looked on the internet and you go down those rabbit holes of that this supplement is the cure, or this treatment is the cure, or there's some cure in India that's been working really well. Believe me, there is no magic single approach to the COVID long hauler symptoms. Prevention's the best thing. Controversial, I'm not here to get into any controversy about vaccinations or the science or anything. I can tell you what we know, and we study this constantly and have been for 2.5 years now. And I'm on our infection control committee with Trinity Ann Arbor. So we can only look at the science and say what the science shows us. It was Israel where they first reported that people had both the infection and the initial vaccination were much more or much less likely to have long COVID symptoms. Every study done since that confirms that, supports that. The vaccination works. It may not prevent you from getting COVID, but it'll prevent you from getting sicker or decrease the risk of having long COVID. So that's really clear. So preventing COVID and not getting COVID is important. I was out on Halloween night with my dog, that's Maisie down there, and I came across that gravestone. I thought that was pretty good. It's a dead guy laying there. Said, I did my own research. And we get that every day in my life since COVID. Someone comes and says, well, from what I've read, or I did some research on this. I go, that's great. I've been doing this 30 years and I'm a dummy. I read research with a very critical eye and I'm always questioning everything, but you got to follow trends. So I'm always a little wary unless someone's got a very specific question on a treatment about it. So the goal of medical management in post-COVID is really what we do in the world of rehabilitation. We want to improve quality of life, improve function, and minimize side effects and or complications of things long-term, okay? So that's what our goal is. So what we did is we created a comprehensive approach of physicians, therapists, nurses, psychologists, and specialists in the world of rehabilitation to try to approach these. Most COVID conditions can be improved through already established things. We didn't have to reinvent the wheel when we developed the COVID treatment programs. We'd already been doing it in the world of rehabilitation. Concussion is a very good analogy. The COVID patients receive a very similar treatment of what our concussion patients. And there's evidence that indicates that a holistic support of this patient through that illness and onto the road to recovery and improved function is beneficial. And that's what we're seeing. I'll show you some of the numbers that we do in our clinic. There's a number of scales that we've developed that we're looking at. So a patient comes in with long hauler, we think they be treatable, we put them in our treatment program. There's a number of evidence-based objective measures where we can measure their improvement. We'll talk about that in a minute. So this has been kind of an exciting thing for me. Over my 30 years, I've developed a lot of different programs and clinics. This was the first one where we developed them from scratch, so we were able to put together our own objective outcomes, our analytic tools. So it's kind of nice that we're starting from ground zero and getting a whole lot of research potential out of all this. We do exercise testing, we do pulmonary function testing, we do cognitive testing, neuropsych testing on memory and concentration. We are looking at medications that help with symptoms, but that's exactly what it is. None of the medications are curative, no matter what you read out there on the internet. There's not a pill for this that will help you, or will make you recover. It may help the symptoms. So when we prescribe, we're very judicious. I actually prescribe very few medications for long hauler symptoms, although I do every day prescribe a medication. But in general, steroids, you hear that. The goal of a steroid is to inhibit or terminate that autoimmune inflammatory reaction that may be contributing to that. However, you can't use steroids long term. They're pulse. If anybody's ever had some acute pain where they gave you what's called a Medrol dose pack, you get 4 or 5 days of high dose steroid and taper it off. There may be some benefit for that, but not always. It has to be used in the right clinical setting. Pretty much the only time I'll use oral steroids when treating a patient with long hauler is certain headache symptoms. And I probably only use it about once a month. There's a certain set of criteria that we use it. So it's not used very often, and it shouldn't be. There's some theory that statins, what you take for your high cholesterol, may help. For the same reason it takes down the inflammation in the coronary arteries or the heart, may take down the inflammation on these things that trigger this inflammatory response. That's being studied. We don't know that. Statins usually are well tolerated, but some people can't tolerate, they get muscle pain and muscle aches. So the word is out whether that's going to be a good, effective treatment for long hauler. These CCR5 inhibitors, these are antivirals, and right now there's a lot of research going on those. None of those are approved yet for human, and there's some human studies that are started on, but not approved for human use yet. So that's going to be an interesting one, and we're watching that closely, that I think we will have an antiviral that you take long term. Not like what you take when you have the acute infection, but what you take long term to help diminish that autoimmune response. There's some theory that taking an antihistamine, a plain old antihistamine over the counter, might block that inflammation cascade. Possibly, that's over the counter. I don't see a contraindication to it other than the side effects. People get dry mouth, they feel dry and dehydrated with them. Supplements, this one we talk about quite a lot. There's not a lot of great supplements that are proven to help, but I will tell you this. We do support taking magnesium a day, 400 milligram tablet. We've long used magnesium with chronic headaches or with concussion or post-traumatic headaches. It's very benign, it's very cheap. Just a 400 milligram supplement a day may help augment that recovery and improve your function as you recover from the long COVID. We do support the use of omega-3 fatty acids if there's a neurologic involvement. If you have that brain fog, or if you have the neuropathy, omega-3 fatty acid is very helpful in supporting both central nervous system and peripheral nervous system recovery. And so 1,000 milligrams once a day is probably indicated. There's various vitamins, vitamin D and vitamin B12, particularly B12 in those who are a little anemic, may be helpful also. Now you can get all this in one multivitamin, so you don't have to go out and buy the fanciest, most expensive supplements with rose hips and all this stuff in it. Just go get a cheap multivitamin, take one of those once a day. The only thing that might not be in that multivitamin is omega-3 fatty acids, so that you may have to take as a supplement. But as long as you're not taking mega doses of vitamins, your body knows how to extract all the vitamins you need right out of your general diet if you're getting a good diet, but it probably can't hurt to take that supplement during that, okay? Now, this is not a commercial, but I want to tell you what we do in our clinic. So Trinity Health Ann Arbor, right here over in the Ypsilanti campus, actually, yeah, it's on the Ypsilanti side. I don't know if you guys know, but St. Joe or Trinity Health Ann Arbor is big. It actually straddles Ypsilanti and Ann Arbor. So my office is in Ypsilanti, but the hospital's in Ann Arbor, and probably 10 times a day I go back and forth between the two cities. So it's a big organization. But we put this program together, well, we've been working on it about 2 years, but we officially opened it a year ago, a little over a year ago, And we've treated hundreds of long hauler post-COVID patients through this program. It's a multidisciplinary rehabilitation program based in the Reichart building. That's the tall building on the Ypsilanti side. On the campus of Trinity Health Ann Arbor. It's focused on restoring function and improving symptoms for patients suffering from long-term COVID effects. We started seeing patients officially a year ago, or documented. We saw them for a few months before as we were setting up the program. So far we've got as much experience in this field as anywhere in the country. So the program, we call it CRP, we named it the COVID Recovery Program. We didn't want to call it a long hauler clinic or a COVID clinic because we're not treating patients with acute COVID. We're only treating those who have symptoms greater than 4 weeks. And so this program combines experts in physiatry. You've learned that new word today, except for a couple people. A physiatrist is a specialist in physical medicine rehabilitation. Neurology, cardiology, pulmonology. We have a number of physicians involved in this program. And then in this, we have a number of therapy specialists: physical therapy, occupational therapy, speech therapy, recreational therapists, neuropsychologists, all working as a team to help our patients improve their function. We have full neuropsychologic services available, which is pretty unique. Most hospitals and outpatient rehab programs don't have a full-time PhD neuropsychologist. We have 3 of them along with 2 psychology counselors, so they're an integral part of that team. When a patient is referred to this program, a primary care physician, your primary care physician or rheumatologist or neurologist can make a referral directly through our hotline here, and I can provide that to David for a resource for later. And this number, if they call, they'll put you in a triage system, which will walk a patient a referral. We don't have to go through all this, but it's basically a system helping us figure out who may need what test, maybe a chest x-ray, maybe blood work, maybe an echocardiogram, get that testing done, and then get you into the right specialist, whether that's pulmonology, cardiology, or rehabilitation. I will say that ultimately it all flows down to rehabilitation because we're kind of the captains of the ship of the COVID recovery program. We oversee the rehabilitation component, but we have input from all the specialists just to make sure we get you to the right place. All right, so let's talk about this team. All right, we doing okay in time, Dave? Okay, good. So let's talk about this team. The rehabilitation team consists of the physiatrists, so we're the captains. We're the one who prescribe the therapies, we prescribe the medications, we do the testing, we do the analytics, and then oversee that team in a conference. At the table are physical therapists, occupational therapists, speech therapists, recreational therapists, psychologists, neuropsychologists, and specialists in work, because a lot of patients we'll talk about here in a minute have trouble at work or getting back to work or school or whatnot. Yes, please.
The phone number you flashed previously,
Mhm.
is that the number? Yeah, can you put that up?
Yep.
Is that the number
Yep, you can, yeah, so we'll talk at the end a couple different ways. If you yourself or have a loved one or a neighbor that wants to be assessed in the program, we'll give you a couple resources right at the end, but this one, which is 734.
For this, we'll also email it to you.
Yeah. And then what I'll probably do is give you our office phone number too, because we triage this a lot right through our office, and that is there's 2 different ways, either for a referring doctor, specialist to get in, or a patient directly in the community.
Email the number or this presentation?
The number and the contact information, how you can get in touch with it.
So with this team, all of these therapists, about 60 to 70% of their caseload is COVID, so they're really good at it. So one of the problems in rehabilitation in general, not even associated with just COVID, but you can be you can be a jack of all trades, but master of none. So with long COVID, our experience is you don't want to get a little physical therapy at that therapy site that's close down the road, but then speech therapy over at the hospital. And I know an OT I've heard is really good at this. It's likely that those therapists are not seeing this condition enough to be good at it. They may say they are, but it's likely. My experience, or our experience in the world of rehabilitation, is a therapist needs to be very skilled in the diagnosis they're working with. In other words, greater than 50% of their caseload to be good at something. I'll give you another example of that. If a patient's got an amputation and we have a prosthetic that we're managing, the therapists, more than 50% of their cases will be amputation. That's how you get really good at something, by seeing a lot. So this team, this is what they do. And then we meet, not on Zoom, not on the internet, we meet in person every Friday and review all of the cases. This Friday, I just saw our list, so we're going to have about 70 active cases that we're seeing and treating right now. But we sit in a room and crunch through these things very pragmatically. So, and not every patient who's treated in this program gets every therapy. They may not need it. It all depends on what the symptoms are. But if a patient needs physical therapy, they're going to be looking at headache management, cranial sacral therapy. Perhaps the pain is coming from the neck or myalgias. So we use physical therapy modalities to help with that. We work on conditioning. People with long COVID are very deconditioned. They're weak. They can't walk very far. They get short of breath. So we have a series of pulmonary rehabilitation and cardiac rehabilitation therapy protocols we follow. Vestibular rehabilitation. Vestibular is the fancy term for your balance center of your brain. It turns out that's unrecognized or under-recognized in COVID. It's a cranial nerve that's affected very commonly in COVID survivors, where it affects your balance. So people have a sense of dizziness or the room spinning, and it's highly correlated with visual issues that we also address. We could do pulmonary rehab or customized exercise program to improve conditioning with these therapists. So occupational therapists, many of you may know an OT or work with an OT who look at activities of daily living. How do we do our hygiene? How do we get dressed? How do we do things around the home? But in our program, OTs also do visual exercises. Long hauler patients have a lot of visual difficulties and the ability to track with their vision or seeing double or light sensitivity. And there's a series of exercises that they're going to work with to help improve that. They look at functional activities of daily living, energy conservation. How do you pace yourself? They may look at how you're doing things around the home or at work. I got long COVID, I gotta work, I'm exhausted, I'm on a computer all day. What can we do ergonomically with my computer station or my desk setup? Or simply, where do I park and how do I get out of the building without feeling like it wiped me out? So we're very good at doing worksite analysis up there. We didn't get into it too much, but the neuropathies that long hauler get causes tingling and numbness and weakness in hands and things like that. So the OTs work on functional restoration exercises for the hand, along with splinting. Speech therapy, looking at memory concentration. There's very few cases where COVID causes problems with swallowing. We do see that probably about once every 2 months, and so they work on swallowing. But the speech therapist works on memory, concentration, cognitive issues. I often describe it as exercises for the brain. Think of it like that. And more formal testing, because many, many COVID patients present with difficulties with speed of processing, multitasking, distractibility. We use recreational therapists, looking at mood management, energy conservation techniques, looking at avocational activities that people want to get back into doing, and helping them re-coordinate into their favorite activities to work on endurance and focus. And so they're a direct part of the team. We have psychologists because there's about a 60% incidence of mood and depression, particularly some anxiety, but mainly depression following COVID infection in patients who never had depressive symptomology. It's not rocket science. First of all, you've lost a lot of your function. You feel lousy. You may have been very involved in the medical community and you don't want that. There probably is an organic reason for that depression also. In other words, the post-COVID inflammatory cascade causes an organic depression within the brain itself. We're still sorting that out and trying to figure that out. Nonetheless, we want to treat that. The vast majority we're able to treat with just counseling. So we have a counselor, 2 counselors specific to our program who are specialists at helping patients with those stress reduction techniques, neurobiofeedback, dealing with depression. Very rarely do we have to prescribe a medication for this in our long hauler patients, which is nice. We're trying to minimize medications rather than just throw more meds at a symptom. So the psychologists are very helpful with that.
I have a question.
Yes.
Are you seeing any cases of pseudo or phantom long COVID?
Yes. Yeah. And we don't understand why that is. There is certainly a psychological reason for that. So what he's describing is patients who have symptoms that appear to be long COVID or consistent with long COVID, although they never had an infection. There is no identifiable reason for it. It's not common at all. There are psychological conditions, though, where people, for whatever reason, develop a syndrome. There's something called conversion disorders, so patients sometimes will present with paralysis, like a stroke, half their body's weak, even though they didn't have a stroke. They're not doing that on purpose, they just develop it. We don't know why that is. Oftentimes there's an underlying, sometimes there's an underlying psychiatric condition. Sometimes we never find out how it is. But what we do is we functionally treat them. We treat them as if they've got this, and we find that they often do respond to it. But it's very rare. You don't see that very much. And we have the benefit of having neuropsychologic services for that. So we have special testing called neuropsych testing, which is very extensive testing on how the brain works. It looks at each lobe of the brain function. It looks at things like speed of processing, motor planning, short-term memory, long-term memory, many mental status examinations. There's something called an MMPI in there where we're looking at personality disorders. And this testing will give us validity testing. So there are some patients who may think they have this. This will help confirm a reason why that might be. There unfortunately very rarely are some people who are malingering or faking these symptoms to stay out of work or avoidance or blah, blah, blah. And this testing will help that. It takes about 8 hours to get through this, but it's very sensitive. I always tell patients an MRI takes a picture of the brain, but it doesn't tell us how it works. Neuropsych testing tells us how it works. Yeah, we had a question back there.
Cognitive testing?
Yes. Mm-hmm.
Is that all inclusive or?
Oh, the cognitive testing? Every patient doesn't need it. For instance, before I came over, I saw a COVID patient here who their only remaining symptom is vestibulopathy or dizziness. They don't have any cognitive issues, so I'm not even going to refer for cognitive testing or treatment. Yep. Yeah.
I did have cognitive testing, but it only took, what, 3 to 4 hours?
That could be. Yeah, sometimes you can get through it. Yeah, was it with a PhD neuropsychologist? It has to be with a PhD, not a master's level. They're the ones who do it. Yeah, so you probably did have it. Work conditioning, a lot of patients are affected with work. They just don't have the energy level or the strength, or pain might be limiting, or headaches. So we use occupational therapy to do work hardening to reproduce their work activities, to increase their tolerance to the point we can get them back to work, or make some recommendations ergonomically how they can get to work. So it's nice. It's all involved in one program. Returning to work in long COVID, for many it's a case of returning to work with those symptoms. So that's a little struggle, I think, for some patients. How can I go back to work? I still feel lousy. Well, we find that returning to activity, returning to routine actually is good. The issue is working with the employer to make sure they can accommodate some restrictions, manage expectations, and take away some of that drama. But in general, there's not a contraindication to doing work. Work is good. We want people, that's part of the conditioning process. And they may, worklessness, in other words, kills. We don't want people just sitting at home feeling lousy. We want to get them back into some kind of activity. So we want to facilitate that. They don't have to be 100% fit to go back to work, and it's a very important part. And not only just work, but school also. And so we work with schools and employers on accommodations to get patients who are having these symptoms back on track. So the impact on ability to work, the impact of long COVID, 84% of patients with these have some limitation on their activity. Now they may be working full time, but they'll say, I'm not doing as well, or I'm getting written up, I'm making errors, things like that. 81% of them have brain fog, in other words, difficulty with concentration. 85% have persistent fatigue, can barely make it through the workday. That's okay, you're not dying from that fatigue, it's part of that reconditioning. And about 50% have difficulty handling stress, and that's true. We may need to limit the intensity and duration of work. About 60% of our patients took some time off during that condition. But we're happy to say we don't have 100% success on getting people back to full-time work, but it's in the 90%, which I'm very happy with. Even 45% of patients who are back at work have some sort of limit on their capacity on what they can do, but that's okay. Now, returning to work with long COVID, it's planned, it's supportive, it's coordinated. We write prescriptions for that and work along with your employer. It takes a multidisciplinary approach, the PTs, OTs, everybody, and each is done case by case. There's no standard algorithm that I use with each employee getting them back to work. It's individualized based on their fitness, and we do a phased approach. Sometimes we're working part-time, 4 hours a day, 2 hours a day, 6 hours a day, adding an hour each week. It's customized for each patient. It's flexible, it has to be accommodating, and maybe hybrid working from home a few hours, going into the office a few hours. And then we see those patients very frequently. The therapists are working with them weekly to make sure this is succeeding. And I see patients monthly in my office after they've had this. So in our program, it's been been officially open for about a year. We have some preliminary data. So our numbers reflect the national numbers. About 60% of the patients in our clinic in Trinity are female. The age range is younger for our clinic. We don't know why. But remember, it's probably skewed because we're an official clinic with referral patterns. But our age range is anywhere between 22 and 64, although we've been seeing a little older patients recently. The majority early on, back in the preliminary data, were unvaccinated. Now the majority are vaccinated that we're seeing and boosted. The majority were hospitalized. That is still true. When you compare those who were and weren't, the majority were hospitalized. And only a few of those ever received any initial treatment like monoclonal antibodies and all that. The majority of them reported improvements in all measures by discharge, and a vast majority were able to return to either work or school. So the program's getting good outcomes. It's a lot of work. It's not simple, but we're getting good outcomes. Anecdotally, there's a number of things that we've identified in the program that we're putting into research right now. The incidence of vestibulopathy is underrecognized. That's the balance problems that patients have with long haul symptoms. They can't quite describe it, but when you test them, they clearly have inner ear dysfunction that we treat. The involvement of cranial nerves is unrecognized. The VOR stands for visual ocular reflex. The ability for eyes to track and see in conjunction with each other is affected. Long haul patients say, "God, when I'm in a car, I can't stand it. The trees go by and I want to throw up." That's the visual ocular reflex, so we treat that. Dysphasias, problems with swallowing, voice. People often are very hoarse after long haul. And they think it's because of the infection. It's not. It's because it affected the swallow centers, which we treat with speech. Spinal accessory nerve, it's an interesting one. I've seen two cases, which is surprising me. It's a single nerve that innervates the muscles through the shoulder and through the chest have been paralyzed. So the virus, for some reason, causes an autoimmune response to attack just one selective nerve. You get these small fiber neuropathies. These are the peripheral neuropathies that cause feet and hands numbness and tingling. It's often in a glove distribution or a stocking distribution. And we deal with that quite a lot because that affects walking, affects the ability to use your hands. We do see a lot of what's called seronegative migrating arthropathies. That's joint pain. We don't know why. These are not like rheumatoid arthritis, but people have joint pain. And oftentimes it migrates. For a week or two, it was in my shoulders, but God, this week it's in my, and there's no swelling. Their blood tests look normal, but for whatever reason, the body is affecting those joints. We were talking about pseudo-COVID here a minute ago, where people have lots of muscle aches and joint pain. In our program, when we do the neuropsych testing, very few of those are somaticizing, or in other words, people magnifying their symptoms. They're valid, and very few of them, in fact, I think we've only had one or two, are outright malingering or secondary gain or trying to avoid work or blah, blah, blah. So they're valid. For whatever reason, people have these symptoms. Hurt doesn't equal harm. That's a hard concept sometimes to learn, that this is, I always say this is kind of like the hand you've been dealt. And so let's try to improve all that symptomology on that. We do know that the earlier we start treatment, the better the functional outcome. We have seen that over the last year. So we're truly encouraging patients, if they're still having their symptoms after 4 weeks, to try to seek more formal treatment rather than let's wait and see. Let's watch and see what happens. Because there is active treatment for this, yes.
My husband had it last January, now it's been a year, and we've never heard of anything like this before. So, I mean, I just thought he was getting old and crazy.
Hey, that's what my wife says too. No, it's not too late. Yeah.
He had a bad case of it.
Yeah, and so it's not too late. So think about our referral. There's many programs. I'm not here to tout our program. Henry Ford has one. The University of Michigan has one. We have one. So many, whatever works out best for you. But it is not too late for assessment and treatment of the symptomology. Yeah, no. And that's one of the things in our experience we're trying to see is, yes, it's important to treat it early, but it's never too late to address some of these issues. I'm not going to go too deep because I want to leave some time for questions, but there's a lot of research that's coming out. We need a lot more though. Because remember, this condition's only been around, this condition recognized for a couple of years now. But COVID-19 can result in prolonged illnesses. Still a lot unknown. We don't know about the long-term effects. I mean, what are COVID survivors going to be like in 4 or 5 years? Are they going to be completely resolved? Is it going to be worse? You know, which of these symptoms are the ones that always persist, and can we address those earlier? How these health problems affect the patient? What's the clinical course and implications for long-term function? You know, because older patients tend to get COVID, we're kind of address this a lot. I'm 3 years away from retirement. I can't afford to do it, except I'm having trouble working. Is this going to mean disability, short-term, long-term, blah, blah, blah. It gets very complicated. President Biden issued a memorandum directing the Secretary of Health and Human Services back in April to coordinate an effort to put together clinics. So there's federal money helping support these clinics and to try to standardize them, okay? And try to put in a central research arm so that we can all pool our data in. That's why if you're going to get assessed in one of these clinics, you're going to be asked a series of questions that we're trying to standardize. So it'll help us understand this. And so the COVID action plan from that, we want to kind of advance prevention again, but make the diagnosis and treatment relatively standardized so there's not all this kind of hocus pocus snake oil stuff that's going on out around there along long COVID. So they're with us, they're launching Centers of Excellence that's going to promote evidence-based outcome. That's through the Agency for Healthcare Research and Quality. And we need to expand and promote access to COVID clinics. Because right now, it's, you know, it's kind of the Wild West. I'm limited by what our promotions budget is. We can only see so many patients in a day. Every day I'm with administrators fighting why I need more therapists for this program. So it's a typical battle. And then there's a number of resources that are being looked at. You know, the Department of Health and Human Services is definitely looking into this. There's underserved populations who don't have access to this care, more or less a diagnosis specifically, and trying to identify and help them. We want to develop these multidisciplinary long hauler COVIDs across the country. There's many regions of the country have nothing like this available. We're blessed here to have several very good programs. And prioritize funding for these patients, ensure that the treatment is not being denied. So frustrating. I've been doing this 30 years, and if anybody's in the healthcare industry here, you know, we're having insurance companies deny treatment for COVID, which if any of that was in the public knowledge, but we have to fight for something as simple as speech therapy in someone who has problems with memory and concentration. It's an absurd concept, but that's our insurance industry. So we're trying to figure out from a federal area to hold accountability with the insurance companies. And we've got to encourage medical training for therapists and physicians. So we're actually incorporating that. St. Joe is a teaching hospital. So we have med students, we have residents, we have physician assistants, and we have nurses who are all in training. And so we're making them go through the long hauler clinic to see patients with us so they understand that. And as this knowledge goes, we're going to see more research with us too. Yeah.
Okay, you said once they're evaluated, they will be placed in a certain clinic?
Yes. Mm-hmm. Yeah, well, the COVID Recovery Clinic is the multidisciplinary program for that. So there might be an evaluation where we say, yes, we think you might benefit from physical therapy for your dizziness, occupational therapy for your visual deficits, speech therapy for your memory concentration. At the same time, I need to get a CAT scan of the lungs because I got to make sure there's not an active infection and things like that. But you'll become part of that program, yeah.
So where would we start with that phone number that was there?
Yep, yeah. So here's some resources in general, and Dave can share this too. This, you know, the CDC webpage on post-COVID actually is very good. That's the www.cdc.gov. The NIH also has a whole series. It's like basically you can watch online. It's 2 days worth of video cast on COVID and long hauler issues. So there's good information out there, and I would stay with the CDC or the NIH to get you the right information without all the drama or without all the advertising and all that. It just gives you the basics, like we've been talking about. Now, locally. So, I like this slide because COVID's like a meandering road. Nobody can find the way to it. But here in this area, your first stop probably is with a primary care physician because they may have a clinic they deal with a lot or they feel comfortable with or they have a good rapport with. And that's certainly a good place to start.
My husband brought it up to his primary care person, and all he had to say was, nothing. I mean, there's nothing we can do.
Yep.
And we didn't
Yep, and so then there's step two. Remember, we have to all advocate for,
Step two.
yep, we all have to advocate for our own health, okay? So then step two is if you can't get that referral from your primary care physician, you don't have to have it. We can kind of backdoor, so, because some insurances require it. If you're Medicare, you don't need that, but if you're in private insurance, you need to do that. But there's ways of doing that. So then step two is a referral yourself into the program for at least the phone call screen on that. That's the triage nurse. That's the phone number I gave you a little bit earlier, okay? The other phone number is to our office, but I think that the triage nurse is the best place to do it because it's single stop, okay?
Start here.
Yep, that's where I would start, yep. And you'll get one of our nurses who are specially trained on this. They know how to walk you through that referral tree, okay? Then you can also go to the website. I shouldn't say this because I think we're changing our website in the next month. But if you go to the old St. Joe website, which still is listed under St. Joe, but now Trinity Health, there's a link for the COVID recovery program. So you can learn a lot more and actually ask questions for referrals into that.
I'll be sending you all these links.
Yeah.
Okay, good.
So
Yeah.
we'll make sure you get this.
Yeah, so don't be afraid if you can't get it through your primary care physician to go ahead and initiate it yourself. So in other words, if it's someone that the nurse says, yeah, we really want to see Dr. Bloom and his associates, then our office is able to get that referral, and it usually works
When we
pretty
go
well.
home, can I call that number first?
Yeah.
Now, is it a long, long wait to get an appointment?
I don't want to talk too much about our program. There's lots of programs. Usually our scheduling for any of these programs are
Okay.
backlogged, so it may take a few weeks, but yeah.
This is all St. Joe's.
Yeah, that's a St. Joe one. I'm sorry, yes, I wasn't clear on that. Yeah, that's not the U of M one or Henry Ford or anything like that. But that's your first start, and they can answer a lot of the
Good, that's a
logistic
start.
questions, yeah.
That's what we want, good, thank you.
All right, good. So what kind of questions we got? I know everybody's got questions, yes.
First of all, thank you very much for the presentation, and thank you for hosting this. Because my daughter's contending with this, just very brief three-part question. It seems that there's no relationship between the severity of COVID and the severity of long COVID. Is that what you are
No,
finding?
no, there is a relationship to long COVID and the severity of the initial infection. So it is more likely if you have more than 5 symptoms that you will suffer from long COVID symptoms, or a very serious infection initially. In other words, those who are on ventilators tend to have long COVID issues more than those who were never hospitalized.
Boy, my daughter must be an anomaly then, because she barely could tell that she even had COVID. It was like a slightly discomfort for 2 days, no loss of smell or taste or any of
Yeah.
that.
Yeah, while we're on
She's
that.
been dealing with this for a while.
Yeah, while we're on that first question, I do want to point that out. We see that a lot. Patients who, they tested positive, it just felt like a little cold. I did my 5 days of isolation, and I just can't get over these symptoms. Or those symptoms kind of get a little worse over the next few weeks, even though the infection goes away. To give you a couple of anecdotes, I've got a full-time, very successful attorney who was very mild. She was vaccinated, boosted, never hospitalized, fever, cough, aches and pains. Just didn't feel right for about 4 to 6 weeks. So she was working out of the house for the most part and not keeping up with her caseload very well, but nothing bad. And when she really had to buckle down and get on her caseload and go in the office, she just couldn't do it. So we've been treating her for several months now. She's back at work about 6 hours a day, but she was a great example. She did everything right and still was stuck with these symptoms.
With our daughter, it seemed like there was a length of time between the COVID and then when she discovered the
Yes.
long COVID.
Yeah.
And the symptoms are varied with her. I mean, it's not the same thing every day. It's one thing and then something else. And
Yes, they often can be variable, or for whatever reason, certain symptoms are worse depending on the environment that day, or stress, or sleep, or all kinds of things.
And then the last, and I understand obviously that this is new to you and to the profession and to all of us. You mentioned the SARS length, and then you used the phrase quality of life, which tends to make me think that a person is going to have to contend with this for the rest of their life. Does your research show that, in other words, do you have any patients that have completed the process and now are not contending with this at all?
Yes. We don't know. This is a new thing. I don't have a crystal ball. Yeah. So that's a very good question. The vast majority of the patients show improvement with the symptoms and definitely function by the end of an aggressive treatment like this. Also, a fair amount, and I can't give you the numbers exactly yet, have complete resolution of their symptoms. So it does work. What we haven't come up with is any criteria of predicting that. I can't look at a patient 2 months into the program and say, yes, you will have a complete resolution within 6 months and a 90% chance of full recovery by a year. There's no indicators that'll tell us that. And I never say never also. If it's like other conditions, particularly neurologic conditions, that recovery happens for months, sometimes it's years. You're gonna hear people say that the long hauler symptoms, if you're not better in 1 year, that's the best it's gonna be. That's not true. We see recovery all the time. It's a little different if the COVID infection affected predominantly the myocardium or the heart, because if there's actual heart damage that occurred with this, that doesn't reverse. Pulmonary tissue may reverse though. It's kind of like a 20-pack year smoker. If they stop smoking after about 20 years, most of those deficits will kind of resolve or reverse themselves. So, but the cardiac tissue doesn't happen as much.
Have you quit smoking what now?
In a regular smoker, once you've stopped smoking, over time the lungs can reverse some of that damage that's done. And COVID's like that in the lungs too. The one side note of that is loss of taste and smell, asomnia it's called. Those are very tiny cranial nerves. Actually, the loss of the sense of smell is the first olfactory nerve. It's a nerve that goes directly from the nose up to the olfactory lobe, which is right here. Taste is much more complicated. It goes through the cranial nerve 7, back into the midbrain. It's got all kinds of things. Those, and in that, for taste, the nerve is actually affected. For smell, it's actually the mucosa and the tiny nerves in the nose. That recovery is really slow. And it is more likely than not that if that symptom is still there after a year, or those symptoms, that you won't have a full recovery. But it may continue to improve, so I never say never. And I put my foot in my mouth. After 30 years, I've realized never be 100% confident on anything in medicine. Yes?
I have arthritis. I've been getting shots in my knees
Mhm.
for the better part of a year. They work great,
Mhm.
cortisone shots.
Yes.
Since I've had the long haul COVID, they quit working. Do you know, is there a correlation to that, or?
Yes. Yeah, are they doing steroid or something called Synvis, which is the artificial?
They tried the gel once.
Yeah.
It never worked, and that was before.
So you're
COVID.
just getting steroid injection,
But
yeah.
just the cortisone,
Yeah.
which again worked great. It no longer is working. I wonder if I could see improvement and they start working again.
Yes, you could. So we don't know why, but the arthralgias, which are non-rheumatologic, so in other words, it's not rheumatoid arthritis or lupus or anything, it triggers this autoimmune response within all aspects of the soft tissue. So the reason steroids work for your complaint is you have osteoarthritis where the disc is worn down and you're getting closer to bone and bone. So when you put steroid within that joint, that takes down all that inflammation on the surface. That's not where COVID's causing problems. It's causing problems at not only the cartilage, but in the bone and the muscles around that. So putting steroid just between two joints, that steroid sits in there and takes away that inflammation. It does nothing for the rest of the articular surface. So there is hope that that will improve and that the steroids might start helping again.
Great. And one more thing, is there a local support group online or something that we could?
There is not a local, there is a statewide long hauler support group, and if you go, I think it's under michigan.gov. So michigan.gov also has a COVID information line. I don't think it's that good. The CDC is better, but they have a support group. Now, a word of caution. I've been doing this 30 years, so I'm kind of direct and blunt and pragmatic. Be careful. There's some wonderful support groups out there and wonderful resources. There are some terrible support groups out there and terrible resources. So it's easy to get sucked into a lot of misinformation, a lot of drama in it. So buyer beware, caveat emptor. In fact, we hear that a lot. So patients who we put into our program who have kind of done all that support group online stuff, come into the program and then they're with other patients with valid, real long hauler symptoms, and they learn way more by interacting with each other through the program and come away with a little different opinion. And I'm thrilled. It's a new program. We're actually graduating leaders in getting this information out to their community. And there's so much misinformation. Every day I'm kind of explaining to someone why some snake oil doesn't work. And there's a lot of expensive treatments out there, and someone recently went to, I think it was South America, and paid a lot of money for stem cell transplants into their nasal mucosa to help with their sense of smell. So I think they said it was about $80,000. So they literally had someone put a lumbar puncture needle into their back, would draw cerebral spinal fluid, which actually has very few stem cells in it, take it, put it in their nose and inject it. And so the first time they breathed out or blew their nose, they probably lost all those cells, with the idea that that was going to grow new cells within their nose. So, yes.
I'm sorry, last thing. Dr. Kriswari, is she in your?
Yes,
group?
yeah,
Okay.
yeah. And Dr. Kriswari has an office up here. Actually, our group has an office up here. So ultimately, if you get referred, you wouldn't even have to drive to Ipsy.
Where is the office?
I gotta be honest, I don't know because I don't come up here. Do you know where it is?
It's off of Canton 7 by Palmer. Palmer
Palmer
and
and
Canton
Canton
7.
Oh, okay, Palmer.
It's in St. Joe's.
Oh, yeah,
Urgent.
urgent care.
Yeah, it's part of the Trinity, whatever the thing is, yeah. In fact, it's not only just Dr. Kriswari. So we've got more doctors and more appointment times, because Dr. Kriswari's coming, Dr. Docking, Dr. Young, and we have a new partner who's joining us in January. So we'll have 4 doctors up here, and I think that means we'll have someone up here 5 days a week, both morning and afternoon, I think. So, yeah, so that'll be a lot easier. Yes?
Got a couple of questions. One is you suggested different vitamins like magnesium.
Yes.
What about the vitamin of 1 a day? Is that a good one to take?
Yes, that will have everything except the omega-3. I would recommend omega-3 fatty acid 1,000 milligrams a day. It's fish oil.
1,000 a day.
Yep. Some people don't tolerate it because they get gas and stuff from it.
Is the COVID, is that a variation of the SARS?
Yes. Mhm.
Okay, because we had very little information on the SARS. Nothing. I couldn't find a thing on it.
It's been out there for years. There's different versions of this, but COVID, this version, COVID, the SARS infection, COVID is a type of SARS. It's SARS-CoV-2. We've known about SARS and we've had research on it, but it never became epidemic like this. And so it's just, for whatever reason, a very virulent form of it.
Very rare.
Virulent meaning nasty.
Okay. What about what I would call the mild COVID? Because both of us have had COVID, we've been tested for it, and we had it, but never had any symptoms or anything like that. Is that something that we still need to be tested for again?
No, no. So you haven't had any long-term problems from it. You had the infection, it was mild. Yeah, all I recommend is live life, get your booster. The bivalent's available now, it's free. Yeah, I just got mine recently at CVS and took 2 minutes. I walked in, got it, walked out, no problem. In fact, I got my flu the same day.
That we've had double booster
Yep.
and everything.
Yeah, so you follow the recommendations for when the vaccine comes out. And there'll be another one. I think vaccines are just going to become a part of our life with this infection.
What was the difference? We were told that there's 2 different vaccines, Pfizer and
Moderna. Mhm.
They are interchangeable, is what we were told.
Now, yes, yeah. Initially, when you get your first vaccine, and you would get 2 rounds of it, other than Johnson & Johnson was just 1. You wanted to make sure the second one was of the same brand, although we're probably finding now that that wasn't true. At the time, we thought that was true. So now the bivalent, both, Pfizer's the main one, that's what you see, but there is Moderna out there. It doesn't matter. Get either.
Interchangeable.
Yep. There's no reason to get the opposite on purpose. Just get whichever one's available. Yes? Mhm.
Are you finding people causing like lupus or
Yes.
other autoimmune diseases now occur that somebody didn't have before, and it's the consequence of having COVID, it triggers something?
Yes, that is the trigger of the autoimmune response. We don't know why that is, and thankfully, it's not common, but if you're the unfortunate individual who has it. So what she's asking is, can the COVID infection trigger a more severe rheumatologic condition like lupus? It's not common, it's pretty rare in fact, but we are seeing that. We don't know why that is. It's most likely that you have a hereditary predisposition for one of these rheumatologic conditions. And the COVID infection just caused enough autoimmune response in your own body to develop those symptoms. And then If it's truly lupus, there are indicators, blood tests that will show that it is lupus. There are some patients with lupus-like symptoms who don't test positive for lupus, an ANA or a spotted speckled pattern. So that we don't quite have sorted out yet, but it is, we do see it. Yes?
Lupus and MS are very mysterious in the sense that they're kind of in and out. Patients have them, and there's no symptoms, sometimes for years and years. This hasn't been around that long for you to see enough sample on that, but do you suspect that this may fall into that same?
No. No, what you're describing is called relapsing remitting. MS is very common for that. Lupus gets so MS is a neurologic condition. Lupus is a rheumatologic condition affecting joints. But they get remitting and relapsing. So yeah, you get a flare up and it gets better, you get a flare up later. There's no evidence based on other virology trends that we've seen that this is something that comes and goes. For instance, Epstein-Barr virus, which is notorious for chronic fatigue syndrome, people may have days where they're not as tired, but they have days, but it's always there. It just doesn't come and go. Yeah, and so all evidence is that this would be the same. Yes?
We have an online question.
Yes.
She says, my husband had a life-threatening vaccine reaction in March of '21. He was showing some improvement by December when he contracted COVID. He has long haul and is surviving but not thriving. He's currently on FLCCC protocol for vaccine injury. Improvement is very slow. Concerns are blood clots, extreme fatigue, brain fog, peripheral neuropathy, weight loss, sleep disturbance, no appetite. What would you recommend?
I would recommend a referral to a COVID recovery program. Yeah, there's no question. Those symptoms we would address. He's already, what she's saying, he's already plugged into a system that is monitoring for patients who have had vaccine responses, and there are vaccine responses. They're extremely rare. Unfortunately, this individual had that. And so, meaning moving forward, they likely won't get another vaccination, or if they are, it's going to be medically supervised where there's certain things you can do to help minimize that response. But the fact that they've had or still have these symptoms means pragmatically in a program like ours, treat it. It's it's treatable, and it should be treated. The big question is whether or not they get vaccinated again, but because that's a complicated case, not like general, garden variety patient. It's under medical supervision where it should be. Oh, and someone usually asks this question is, does a vaccine treat long hauler? There's no evidence of that yet. We can't say that. Anecdotally, people think I had long hauler, I got my booster, and boy, it really made a big difference. I feel much better now. That's just anecdotal. We don't know if there's any science in that yet. Yes, question back there.
So, I had COVID when it first came out in March of
2020?
when they didn't know much about it.
Right.
Very ill, hospitalized, not vented, but with oxygen and double pneumonia, the works. Are you seeing patients that were that ill back in 2020 now in your clinic with long haulers symptoms?
We are seeing patients, you mean that new symptoms that are developed? So didn't have any symptoms for a long time and now developing symptoms?
Well, it took a while for recovery.
Yeah.
So after recovery, and then you start thinking you're feeling better than you were when you
Yeah.
were definitely ill. But now you're having symptoms of long haul.
Yeah, most commonly, patients who are presenting have ongoing symptoms all the way through. We very rarely have a patient who had a severe illness, felt 90% better, and now, for whatever reason, oh boy, I backslid. I have more fatigue, I have more headaches, I have more cognitive issues. We do see that. So that's an important case to be able to be worked up in terms of blood tests and other testing, because we want to make sure there's not something else going on. We're all human, we age, and 2 years is a long period of time. There might be something else causing it. So then we do that series of tests to make sure there's not some other cause that has nothing to do with your previous COVID infection. And then if there's not, and the symptoms look treatable within the program, then we just treat you in the program. We just do it because it's got the same symptoms. And we're also seeing patients who get a secondary infection but never tested. And they probably had COVID again, maybe didn't know it.
couple more questions and then we'll wrap up. Anybody else?
Is there a local phone number we could call? Or should we use the,
Use that number we just gave you. That. Yep, it's a COVID hotline.
that's
Yep, one-stop shopping. That's the best place to get it put in. Yep.
What are the, I know there's some testing that's gonna be planned, trials for like Paxlovid and things like that.
Yeah.
What are your thoughts on that?
For Paxlovid, Paxlovid, yeah, definitely. It has to be used within 5 days of the
Oh, no, I
onset.
meant for treating long COVID.
Oh, treatment. Oh, there are studies that are in the animal portion. There's one study that's going into humans, but it's very, very specialized stuff. The problem with medical research, as you probably all know, is it takes years to get through the formal IRB approval. There was fast tracking of the vaccination, but that's a whole different thing. So human studies for treatment is going to occur, but it's not going to occur quickly. And the fact that it was a pandemic helps it a lot. Things that are high profile or affect a lot of people get the funding for it.
I think I read they were gonna start in January.
For which agent? There's a few different agents.
It was
It's the antiviral, it's a CCR5B. Yep, yeah, I think the human studies on that are gonna be advancing pretty quickly, yeah. Because, those antivirals were already out. We had been looking at those with MERS, SARS, a couple others. So those medications were being looked at other viruses. So I think all they've done is moved a whole different arm of research into COV2.
Also, I would presume you also know what safe doses are too.
No one knows, no one knows,
Oh,
yeah,
okay,
no one
okay,
knows,
all right, I
yeah.
was gonna say,
Yeah, that's what the human
majority
studies do,
are
yeah.
using them on humans.
Well, they're not, yeah, they're not supposed to be,
Not that-
but yeah,
okay.
yeah. Yeah, I wish it was, yeah.
That's okay.
Okay, in the interest of time, I'll call time. We'll hang out up here if you'd like to have a word afterwards, but just kind of keeping us on schedule. I'll be that guy in the questions now, but we'll be around. I'll also be sending out, Beth and I will be sending out emails with all the information that you've covered. If you have any questions or you didn't get the email, please reach out to us. We will have that info for you so you can get whatever you need.